Jonas from the University of Cape Town, and I want to welcome you all to this GECO meeting, the first HCC GECO of 2022. And just again to thank Project ECHO of from the University of New Mexico that cooperate in this project, or we cooperate with them. These sessions are held weekly on a Wednesday at 16:30 Central African time. So for this meeting, I think we had almost 70 registrations. We'll see how many people will be able to join. So when we counted the last time, it was from 14 sub-Saharan African countries. So I'm just going to introduce the speakers, and I will introduce all three of them at the beginning. First of all, Dr. Michael Okelle, HPB surgeon from Makerere University in Kampala, Uganda. It's really a privilege for us to have Michael on today, and he's going to talk to us on the management of HCC in Uganda. And that will be followed by Dr. Mark Bernon, hepatopancreatibular surgeon from Cape Town, that's going to talk to us on the surgical treatment of HCC. And we'll finish off with a case report by Dr. Mtimkulu, one of the HPB fellows with us in Cape Town. So Michael, thank you very much again, and we're really looking forward to your talk.
Thank you, Professor Ed. Can I go ahead?
Sure, you can go ahead. Thanks.
All right.
Great, we see your presentation as well, so fantastic.
All right, thank you. So I'm going to share on management of HCC in Uganda. And when Professor Ed asked me to prepare this topic, I hesitated because there's not a lot of data on management of HCC specifically in Uganda. But we'll go through what we are doing so far. So we'll have a short introduction on HCC management in general, and then the history of HCC management in Uganda, and then the current available management options we have in Uganda. And then I will share our HPB data that we've been doing, and this will contain some bit of HCC management. And then a short video clip on liver surgery at Lubaga Hospital, and then conclusion, then we can take the questions. So in the introduction, most of these slides we are familiar with them. This is from the European Association for the Study of Liver. We all know liver cancer is the 5th most common cancer and the 2nd most frequent cause of cancer-related death globally. We have about 854,000 new cases and 810,000 deaths per year. And 7% of all cancers is HCC. Now, HCC accounts for approximately 90% of the primary liver cancers, and therefore constitutes a major global health problem. When we look at the etiology, 90% of HCCs have underlying etiology. Commonly, the viruses, hepatitis C virus, hepatitis B. We have a lot of alcohol. We have some small contribution from the metabolic diseases, non-alcoholic fatty liver disease, or non-alcoholic steatohepatitis. And then we also have aflatoxin exposure from nuts and maize and all those nuts. So when you look at the contribution of the different etiologies, we see alcohol, hepatitis B, hepatitis C, and others. For us in sub-Saharan Africa, you can see alcohol and hepatitis B taking a lead. So we are all familiar with Hcc preventive interventions. So with HCC progression, you have a normal hepatocyte, a normal liver, and then you have a subclinical picture. and then it progresses to cirrhosis, and finally you have either primary HCC or secondary HCC. So if you are to target prevention, primary prevention, you'd have to target the etiology. And then lifestyle issues, and then secondary exposure. If you have hepatitis B, you may need antiviral therapies, hepatitis C, and the rest. And then anti-inflammatory therapies, antifibrotic therapies before you get cirrhosis. Then metabolic disease treatment, and then molecular targeted therapies. The BCLC staging treatment, when you look at the different staging and treatment options that are available, most of our patients in Africa, sub-Saharan Africa, who usually come late, they are not in the very early stage or early stage, most times intermediate and then advanced. And yet the options that we have are also limited. So for Uganda, the history of hepatocellular treatment in Uganda is a bit, when you look at this, is a publication in 1973 by one of the Ugandan surgeons. It's actually credited to be one of the first surgeons in East Africa, Professor Chalwazi. He died in 1992. Uganda had the advantage of having the first medical school in East Africa. And we had a few specialists trained in Edinburgh, and Professor Chalwazi was one of them. We had the neurosurgeon and the rest. And these people pioneered work. Professor Chalwazi started doing liver resections in Uganda in 1969. And unfortunately, I think it was a blessing, but also a problem because there was no good mentoring. Because once he stopped practicing, that was the end. Until again in 2018, when the president of the country sent about 40 specialists to train abroad, and I'm one of the beneficiaries. Most of us were sent to India. Among the 40, we have about three hepatobiliary surgeons, 7 GI surgeons, other people in neurology, and the rest of the other specialties. But when you look at this history, it is unfortunate between 1980s up to 2018, there was no hepatobiliary surgery in the country. And yet we had the advantage of such pioneer surgeons doing liver surgery in the 1960s. So when you look at Professor Chalwazi's work, this is part of the publication of Professor Chalwazi, the work he did in 1969, between 1969 and 1970. We can pay attention, when you look at the age, 18 years, 53, 31, Uganda is known for having a young population. About 50% of the population is under 18. And we are still seeing this when currently the patients I work on. You find a young patient with very advanced disease and you can't do much. So we have that advantage of a young population. And when you have a young population, then you can do aggressive surgery with quite good outcomes. Though when you look at the results, we had about 3 people dying within 2 weeks. So it's a 30% mortality. In the 60s, maybe acceptable. Currently, not acceptable. But that is the history of liver surgery and management. And this was one of the options for management of HCCs then. So having the advantage of having liver surgery in the 60s compared to now we are still limping. I literally started doing liver resections in 2018 after coming back from India. Otherwise, prior to that, there was nothing going on. And I'll share the data that we've accrued so far. Not too many resectable cases. When we go to local regional options, we don't have radiofrequency ablation, we don't have microwave ablation, irreversible electrophoresis, cryoablation. The only thing we do is bactericidal injection. Interventional radiologists do this occasionally, which is quite sad for a country with 40 million people. So all these ablative techniques, which are good for small to medium-sized HCCs, are not available apart from ethanol injection. So we have most of our politicians and the rich people, they fly abroad when they need these services. Even as I speak now, the Speaker of Parliament is in the US for treatment, and the country people were crying because they spent 1.7 billion just for his flight, whole chartered plane. But there's pressure mounting because now it's no longer only the politicians flying abroad. Now, even when you have someone, middle income people in the country, there's a lot of fundraising to try to send them to India. People try their best, wash cars, and even the people who don't have money try to contribute. And yet someone goes out there, gets a transplant, and comes back and struggles with immunosuppression therapy afterwards. And this is a big gap that we have to look into. There's a lot of demand because now people are not comfortable allowing only the politicians to fly out. Even there's pressure from the local population to try to improve services within the country. So the next table, this table basically shares all the HPV surgeries I started in 2018 when I came back from India. We are doing pancreatic resections, whipples, distal pancreatectomies, and liver surgeries, different resections. But in relation to HCC, the numbers are minimal. Total of 6 cases in 2 years. Out of the 16 liver surgeries I've done, just about 6 of them had HCC. The others, about 5 benign giant hemangiomas and the rest. But HCC contribution is just 6 out of the 16. This, we are all familiar with this. I will not go through this. So when we are basically determining whom to resect, we look at the patient performance status, liver function status, comorbidities. With comorbidities, we have a lot of HIV and now also metabolic conditions, diabetes, hypertension. And then, of course, if there's any extrahepatic disease, major vascular involvement, or distant metastasis, we just send them for palliation. The key thing is future liver remnant, at least 30% for normal liver. But where we resect for patients with cirrhosis and the rest, the percentages go up. Otherwise, you risk post-hepatectomy liver failure. This is, I specifically picked this case because this was a 47-year-old young man who was under the care of the oncologist. He had a huge liver mass, 10/12. They did ultrasound guided biopsies, which shouldn't be done in the current thing, but did ultrasound guided biopsy, and the histology came back as HCC. So in view of the size of the tumor and the oncologist started him on sorafenib, but it didn't improve. So by the time they referred to me, I looked at the images and I didn't think it was HCC. So when these were the images, you see a huge but a well circumscribed mass on the left lateral lobe. So I decided to go and resect it. I did a left lateral hepatectomy. This was the intra-op video of that mass. When you look at it, definitely wasn't HCC. So we resected it and sent it for histology. This is this is after resecting the mass. And then that is the mass after resection. We sent it for histology, and the good news came back, the tumor, it was a hemangioma. So sometimes we have those challenges also with the histopathology team reporting malignancy when it is not malignancy and vice versa. So in conclusion, liver resection as an option for surgical management of HCC is possible in Uganda. We have 3 hepatobiliary surgeons and about 7 GI surgeons who can safely do liver resections. But challenges, we lack the radiofrequency ablation, microwave ablation, and all the others. And then, of course, we don't have liver transplant. Our transplant law is not yet out. It has been discussed by Parliament, and it has been approved by Parliament and Cabinet, and it's awaiting a presidential assent. But this is a long way to go. And then, of course, patients presenting late is a big challenge. Most of them come when they are not resectable. Key positive is we have that relatively young patient population. So sometimes we resect patients who are not within criteria, the Milan criteria and the rest. So because they are young, fit, we try to resect them, and they do well. I welcome questions. Thank you.
Thank you, Michael, very much for a really very complete presentation and the overview of how you treat HCC in Uganda. You made the comment first that you don't have much data, and we know that is really a big problem in sub-Saharan Africa, that there's basically not a lot of data from any of the countries, and I want to include South Africa in that as well. So this is, I think, indeed one of the purposes of these meetings is to get people together, and just the numbers that you've mentioned in your presentation already, I think is fantastic, and it already gives us an indication of what needs to be done. And I really like the template that you had, and it's almost a template that one would like the future presentations from other countries to follow, to say exactly what the situation is in terms of the treatment capabilities and also the number of patients that are treated, and the limitations and problems that we face. I just want to raise something with you. So you mentioned liver transplantation, and obviously liver transplantation has become a big article in countries where transplantation is available for some of these patients. And I think in the countries with high incidences, as some of the South Asian countries, HCC is one of the major indications for liver transplantation. Now, I understand in Uganda, you're not there yet to start a program, but how do you think a program should be started? Because I know there's been sporadic transplants amongst other countries in West Africa, where I think surgeons from, if I'm not mistaken, from Egypt travel there and then do living-related donor transplants. How do you, because you've been in India, you see how they do it there. What do you think is the way forward of starting that in Africa?
Thank you, Professor Edward. Liver transplant currently is a long way, but as long as there's political will, because for the situation of Uganda, our national referral, Mulago, the government put in a lot of billions to renovate it. And one of the key issues was it was meant to do specialized services. And in one of the planning options, they built a transplant theater, and we have transplant. That's why they sent us out to train. But it's like the things with government move very slow. But if there's government support, you can have a low volume transplant center. I mean, if you do one transplant in a month, it's better than nothing, because if you look at the billions, there are countries, these are poor countries, but we're spending a lot of billions to send people abroad. And most times they come back with complications, and it's us again to address them. they get excited. Especially the Asian countries, they're aggressive at marketing. So, and yet they don't give the entire picture that after transplant, you're going to have challenges of rejection and all these complications. So even if we decide to say, let's not transplant, let's not plan for transplant for the next 50 years, people will keep going out of the country, even the poor people. Right now in my hospital, there's one of the staffs, the entire hospital is fundraising to send the patient to India for transplant. They are not rich, but trust me, they have already raised about the money for the transplant. They will hustle with the post-transplant complications later. But when you try to talk to them, it is more of an emotional issue. You either get a transplant or die, so people are willing to do anything to try to survive. So we may have to think about getting at least a low-volume transplant center within the regions, at least one in East Africa and one, something like that. Otherwise, if we choose to just wait forever, people will find a way, and Indians are aggressive, people will go out of the country.
No, thank you very much. I think that's a very sort of sober view of what is going on. I think that there's not a question that in the long run we have to offer this to our patients. The problem is to establish transplant programs in countries where we haven't established, as you already mentioned, even in Uganda, solid HPV centers with liver resection being almost a routine procedure. So I think that those are the odds that we're up against. I see, Mark, you've got your hand up. And if there's anybody else with any comments, you're welcome to place questions in the chat group, or you can just raise a hand.
Thanks, Ed. Thanks, Michael. That was a really interesting talk. I really enjoyed listening to it. I was just wondering, do you have TACE available in Uganda in your hospital?
No.
So I'm sure there are people who are doing angiograms. We've had the idea of maybe getting people, whether it's a vascular surgeon or a cardiologist, to get a workshop going where someone who's already doing angiograms comes to learn how to do TACE, because then you don't have to teach someone a whole new skill set. Would you have someone who would potentially be interested in doing that, do you think?
Yes, we have, the best would be an interventional radiologist. We already have a few interventional radiologists. One who trained with us in India already left the country for greener pastures. I think he ended up somewhere in Botswana. But we have other interventional radiologists, and we have more radiologists who are interested in training. And the current ones are biased towards neurovascular interventions and should be easier to interest one of them. If there's a training opportunity, I can get you a radiologist.
That'll be okay. Thanks.
Wendy, I see you've got your hand up.
Yeah, I just want to sort of comment on the really need for interventional radiology. I mean, if we look at liver transplantation, we're probably going to be looking at living-related liver transplantation. And I think we all know the long-term risk of biliary complications and the need for actually quite access really to interventional radiology that can deal with biliary strictures. I think we often underestimate the need for that. And that really, if one's setting up a complex hepatobiliary surgical system, I think that's essential to have that support system as well. And one should really develop that in tandem with one's surgical capabilities. Thanks.
Yeah, thanks, Wendy.
Yeah.
If no other comments or questions at this stage, I think we can move on. Mark Bernon is going to sort of enlighten us on the surgical treatment of HCC. Thanks, Mark.
Thanks, Ed. Can you see my screen? Sorry, I just want to go back. Can you see that?
Yeah, all good.
Okay, thanks. So I'm just going to talk about liver resection in quite general terms, and mainly just to stimulate some discussion, hopefully towards the end. But as many of us know, there are three potentially curative treatment options for HCC, ranging from ablation, which can be thermal or chemical ablation, to transplantation. And transplantation probably has the best disease-free and overall survival, but it comes at a cost, and that cost is morbidity and mortality. And And the morbidity and mortality, or the mortality of a liver transplant, is generally considered in most of the literature to be about double the mortality of a liver resection. And considering the difficulties getting patients transplanted, I think generally if a patient can be resected, in most instances we should go with resection before transplantation. Coming down to liver resection for hepatocellular carcinoma, there's various algorithms, and as we saw, the BCLC algorithm for trying to decide on what the best treatment option is for a specific stage. In Africa, as has been mentioned, we have a large number of non-cirrhotic patients with HCC that's often hepatitis B associated, and also in young patients, as was mentioned also. So we can often do quite big liver resections in patients with HCC. In cirrhotic patients, if we go according to the Barcelona staging system, which I'll go into more detail, it's really based on tumor factors, factors that look at liver function and the performance status. And it's quite limiting in the number of patients that they recommend for liver resection. So if the BCLC criteria are accepted quite widely in Europe and in America, but not as much in the East. If you transplant patients within the Barcelona, if you resect patients within the Barcelona criteria, you can expect to have a 5-year survival of over 70%. When considering liver resections in cirrhotic patients, the mortality and the morbidity is quite significantly or quite a lot higher than patients who are resected who are not cirrhotic. And you have to factor in the fact that you can't resect large amounts of liver, that the liver resections are generally limited to patients with good liver function. So non-anatomical resections are often the way to go in patients with cirrhosis. But having said that, it is possible to extend the resection criteria even in cirrhotic patients and still have good results. And I'm just going to touch on that a bit later. And I think we must always remember that liver failure is the biggest cause of postoperative mortality after liver resection, and that is particularly a problem in patients with cirrhosis. So as I mentioned, if you look at the Barcelona criteria, they essentially limit resection to patients with very, very small tumors, which is not always appropriate, and there certainly are patients with more advanced disease that potentially benefit from liver resection. And I think these criteria on the Barcelona clinic staging system is not really ideal for us in sub-Saharan Africa either, because liver transplantation is not widely available, and I think we have to try and probably extend the resection criteria because of that. If you look at resections that are done beyond the Barcelona liver criteria, this paper shows that it can be done. And if you look at the patients who have large HCCs, who are BCLC-B, they can be done with, in some cases, not such poor results. I often think that there are some, what we often say that size is a marker for aggressive disease, but I don't always think that is true. A large tumor could be something that's been present for a very long time and not be very aggressive. So one of the important things when considering resections is trying to assess tumor biology, and that's something that's not really factored into a lot of the criteria. Like Uganda, there are really not very good we don't really have a lot of data on HCC in South Africa. We're trying to improve our data collection at Resections Hospital. And if you look over quite a long period, from a 5-year period almost, we managed to enter 152 patients onto our HCC database. And I have shown this data at this meeting before. By far, the majority of them were treated with palliative intent. We only managed to treat 21 patients with curative intent, and 12 patients had liver resections in that period. If you consider liver resections in non-cirrhotic patients, so that's probably about half of our patients, we are able to do more extensive resections. Volume manipulation can be used in these patients, a bit like patients with colorectal liver metastases, so things like portal vein embolization and staged resections. And one of the factors in these patients that we have to consider is identifying and treating the underlying pathology, which is often hepatitis B, and we're lucky that there are now good treatments for hepatitis B. So coming back to our data, as you can see there, 50% of the resected patients had cirrhosis. Only one was not Child-Pugh A, and our overall median survival was 24 months. Our 60-day perioperative mortality was 8%, and 50% of the patients are still alive. So liver resections can be done safely in some sub-Saharan Africa. And I put this here just to show the two different groups of patients that we have. You have your cirrhotic patients. This patient did have hepatitis B. He's got a small little pedunculated tumor hanging off the bottom of segment 4B. This patient had portal hypertension, but that resection can be done quite safely and quite easily with resecting a small amount of liver. So those are often the types of resections that get done in patients with cirrhosis. And then in contrast, the scan on the right is a patient also with hepatitis B, not cirrhotic, with 3 large tumors confined to the right side of the liver. And this patient had a right hepatectomy. So, in the patients without cirrhosis, you're able to do more extensive resections. So another thing that I always wonder about is when we're considering patients for transplant, we always focus on whether there's portal vein invasion, and portal vein invasion is considered a contraindication in most criteria for transplantation. But what happens if you've got portal vein invasion in a patient who's a potential resection candidate? And there are various criteria for classifying portal vein tumor thrombosis. And this is something that we've started to look into, and I think it's worth really looking at and classifying the portal vein thrombosis better. And I do think that you can do resections in patients with portal vein thrombosis, but you should probably resect the part of the liver that is supplied by the vein that is invaded. Because we all know that once you get portal vein invasion, you often get multiple satellite nodules in that part of the liver. So, if you got a non-cirrhotic patient where the right portal vein is invaded by tumor, you probably have to resect the whole right side of the liver. If a very peripheral or small branch of the portal vein is invaded, then you probably don't have to worry about it so much. And then something that we're not very good at now, but I think something that is quite important, and in the case that we're going to present, we'll touch on it, is testing tumor biology. Just because you can cut a tumor out or you can transplant a patient doesn't necessarily mean that you can do it. And like I said, size is not always the best marker for aggressiveness, and that's one of the problems with with the transplant criteria that are commonly used. Other things that are important, I think, are the alpha-fetoprotein. What's quite advantageous is if you can taste a patient, and a patient that you're worried about, and see how they do over the next three or 4 months. And if they have a good response and you've got stable disease, that patient's far more likely to benefit from some type of surgical resection. If you treat the patient and 3 months later there's tumor all over the liver, or there's tumor outside the liver, you've probably saved that patient an unnecessary or non-therapeutic liver resection. There are some liver transplant criteria now. If you look at the Toronto criteria that look at the grade of tumor when deciding on whether a patient should be listed, and they've managed to transplant patients with quite large tumor burden who have low-grade tumors, and that's something that we haven't really looked at, but whether one should consider, because we don't really like to biopsy these tumors, but whether the grade of a tumor does factor into the tumor biology and how these patients do in the longer term. Yeah, so that's basically what I have to say. We're going to have a little case presentation, but I'm not sure if anyone has any questions or comments.
Yeah, we can just see, Mark, if there's anybody. Just in the meantime, I just have a comment. As you already mentioned, is the Barcelona criteria that we kind of regard as the backbone of most of the guidelines. If you look at the EASL guidelines and the American AASLD guidelines, they're all basically based on the Barcelona criteria, and none of the Southeast Asia guidelines are based on that. And I think we're a little bit in the same situation. So Michael's already mentioned that a lot of our patients are young, and sort of can actually take quite some surgery, as opposed to, I think, some populations with these patients, especially if they go the cirrhotic pathway, are quite a bit older. And then the other thing is that a lot of patients or a much larger proportion than in other countries, because of the prevalence of and incidence of hepatitis B, are not cirrhotic. And then again, the Barcelona criteria are very restrictive if you apply them to the non-cirrhotic group. I don't know if there are any other comments.
So Ed, yeah, I do think we are applying criteria that seem to have been developed in the West to our situation, where the etiology of liver disease is completely different. And I think, especially when you're looking at transplant criteria, I wonder whether we are not applying criteria that make us be too conservative. And I'm not saying we should transplant everyone, but we need to try and get better at selecting patients who are going to do well. And I think purely basing it on the tumor volume is too simplistic and too restrictive. And we can probably do better and transplant more patients, still having quite good results.
I mean, if you look at the 6 patients we've transplanted, the results are a little bit too good.
Yeah.
So far. So I think most people would accept slightly lower overall survival. Wendy, I think, yeah, you've got your hand up.
I just wanted to ask Mark really to comment on the importance of assessing the volume of the residual liver when one's doing a resection, and whether that's important in your decision, whether they're doing a formal assessment of residual liver volume when one's doing an extensive resection.
So I think it really is important especially when you're doing bigger resections. So the teaching is that if you've got a cirrhotic liver and the person is Child-Pugh A, that it's felt to be safe to resect 50% of the liver. That's quite a crude assessment, but we probably wouldn't want to resect much more than that. There are functional tests that you can do to try and assess how much liver volume it is safe to resect in patients with a cirrhotic liver. There's the indiocyanine green excretion test, which is not really that available, but it's something that can be used. So in the cirrhotic patients, we often do quite small resections. So I don't think liver volume assessment's that useful there. But in the non-cirrhotics, where you might be considering doing an extended hepatectomy, it can be quite useful to help you decide whether you want to do a portal vein embolization, or maybe you'll do a portal vein ligation if you don't have portal vein embolization available, and do a staged procedure. So I do think it is helpful, and you just need to have the software available to do it.
Thanks.
I think the only guidelines or algorithm that I know about that is helpful in that is actually one that Mikuchi designed, based on the ICG retention, where the certain brackets of how much of it is sort of retention there is would say how big the liver resection could be. Because this thing about, you know, if there's cirrhosis, you can do 50% or 30%, and we know, and that's why we've got the Child-Pugh and the other classifications. You've got a whole spread of severities for cirrhosis, and to sort of have like a single number as a cutoff, I think is not very helpful. The other problem is that, and there's a little bit of evidence for that as well, is that the function is not equally distributed in these livers. So volume can be a little bit deceptive, because that part of the liver may be functioning worse than other parts that's actually carrying the function.
Michael, you had a comment.
Yeah, I had a question. This issue of tumor biology, there's a concept of ablate and wait, or watch and wait. I find it very difficult to determine which tumor is aggressive. You've said you can't judge based on size. Alpha fetoprotein, sometimes FP, sometimes you see some aggressive tumors with low FP. I don't know whether you've seen some, but what is the exact criteria you can use to say this tumor is aggressive, this one is not? Because in India, I was in Medanta does a lot of transplants. They do an average of 20 transplants a month, the center where I was. But sometimes they also transplant outside criteria. And I've seen a patient with HCC recur almost immediately. We're all shocked. About, I think it was like 3 months. So the issue of tumor biology, are there clear markers you can use to say most likely this is an aggressive tumor, or this is not?
So the problem is, I don't think there is, and even having a high alpha fetoprotein will make you worried, obviously. But I'm sure you've, you know, when you've resected tumors where the alpha fetoprotein is very high, and after the surgery, it goes back to normal. That's a really, for me, that's a really good prognostic sign. If it stays high, then there's likely extrahepatic disease. So a nice way for me of trying to assess the tumor biology, I think, is doing TACE. You know, if you're worried, I'm not saying you should TACE everyone, but if you've got someone who's sort of borderline resectable, you know, maybe not that fit, and they've got a very high alpha fetoprotein, and you're worried that, you know, is surgery really going to be that beneficial, we will often TACE that patient and wait 3 months. And, you know, sometimes you TACE a patient and the alpha fetoprotein plummets. Sometimes you TACE them and 3 months later there's tumor everywhere. I think that patient, if you'd resected them, the ones where there's tumor everywhere a few months later, that patient was never going to do well with resection. So you know, in a way, you treating it and seeing what happens. That's probably the best way that we have of assessing tumor biology at the moment. It would be really nice if we had better ways of doing it, but at the moment, I think it's almost like tasting, seeing what happens, and that's the best way of assessing the tumor biology. But I'm not saying that we should do that in everyone, because there are some patients that really do warrant upfront surgery. Yeah.
Okay, thanks, Mark. I think Karan has got his hand up as well. Karan Gandhi from Nairobi, and then after that, I think we can move on to Wanga's case. Okay, Karan, please.
Thanks, Prof. Thanks, Mark. And I just wanted to add that there's no one size fits all when it comes to assessing tumor biology. Obviously, it's a concept that's very interesting, and it's something that we really don't have a lot of evidence for to tell us what good tumor biology surrogate markers are and what bad are. So at the moment, all we're using is using surrogate markers. So size is one of them. alpha-fetoprotein level is one of them. And as Mark has correctly said, the response to taste. And I think you can't look at one factor individually. It has to be multiple factors that you look at. So you have to take the patient in totality and then factor in all of these different components that we have available to us. And in addition to that, we also need to look at the patient and how far we're willing to go. And one of the models that I really like is the metro ticket model that we look at for transplant criteria. And I think we can extend that to resection as well. So if it's a younger patient, as Michael has said, as if they are younger patients, then you're willing to go a little bit further and be a bit more aggressive with them. So even if a patient has slightly worse tumor biology based on your surrogate markers, you might be willing to still offer them a resection, not necessarily a transplant, but at least a resection in a case like that. Thanks, that's just my comment.
Thanks, Karan. Okay, Wanga, I think we're ready for your case.
Okay, I'm gonna be presenting a case of Mr. JV. He's a 67-year-old male who presented to us early October 2020. He came in with acute variceal bleed that was managed successfully endoscopically. When he came in at that time, we scored him to be, he had a MELD score of 19 and a child Pew score of, he was a child B, he scored 11 points. Those are just his bloods that are depicted there. He had ascites, he had encephalopathy. So like I said, he was managed successfully for his acute variceal bleed. Part of our protocol in our institution is that every patient that has had an acute variceal bleed, we tend to do some kind of imaging just as a surrogate marker or as a baseline to see if they've got no complications related to things like if a patient doesn't have portal vein thrombosis, doesn't have any tumors, or like doesn't have HCC at that time. So we did scan this patient. On the scan, you can see that he had some ascites and features of portal, of cirrhosis. He's got inhomogeneous or liver, and he's got this hypertrophic right lobe of the liver with hypertrophy of the left and the caudate lobe hypertrophy. At that stage, didn't show any features of portal vein thrombosis. Like I mentioned, he's got ascites and also has got splenomegaly. At that stage, his alpha-fetoprotein was 12. He was discharged successfully. He went on to have his medical treatment. He was treated with covedolol, spironolactone, and furosemide. He recovered quite well afterwards, and he went on to the surveillance program. We generally do 6 monthly alpha-fetoproteins and ultrasound scans. Just of note, he's also known with ischemic heart disease. He's had quite a few stents in, but further assessment by cardiologists, they've found him to be quite well. So on follow-up, about a year later, he presented to us again with a rising alpha-fetoprotein. And when we assessed him at that time, his ascites had resolved and he had improved dramatically with the medical treatment. His child Pew score had improved now from the previous score of 11 to 6, and then he scored as an A, and his MELD score also improved. So the concern of the rising alpha-fetoprotein, we did ultrasound, which didn't show any tumors. So we opted to do a CT scan on him. By the time we did the scan already, the tumor markers were already rising, and it was almost 4,000. So we did scan him, and on the CT scan that we did, if you appreciate on the scan, it's an arterial phase. This is what I'm going to show you. You can still see the features of portal hypertension there, the right lobe atrophy and hypertrophy of the right side. Otherwise, he doesn't have any vascular abnormality. And then you can appreciate that on his on segment 3, he's got a hypodense mass, but this mass doesn't take up contrast, but you can appreciate there that there is some hypodense lesion there, and it lies very close to the segment 3 portal vein. And like I've already mentioned, clinically, when also radiologically, his ascites had already improved. So just to proceed to the portovenous phase. So this lesion does demonstrate a significant washout, even though it doesn't take much of contrast in the arterial phase, but it does show some kind of a washout in the portovenous phase. We do know that some tumors, about 10% of them, don't show this arterial hypervascularity on the arterial phase, and that was the case with him. So with this tumor that's very close to the portal vein, or the segment 3 tumor, we didn't see any other tumors. The size, just to mention, it is about 3.5 to 4 centimeters in this widest dimension. There was no extrahepatic extension, but the tumor does lie very close to the, as you can see on the slide, it lies very close to the portal vein in segment 3. But it's a very short segment. Otherwise, the rest of the umbilical recess of that vein is free of the tumor. So because of the size and the very close relationship to the portal vein, we opted to do a taste for this patient. By the time we did the taste, the alpha fetoprotein was already 13,000. There was a very good response. He had to get 2 tastes. There was a very good response from the taste, but the tumor basically relatively stayed the same in size, didn't quite change. But then, yeah, so the tumor didn't really change much into, but his alpha fetoprotein responded quite well. Currently, it's about 112. That's his alpha fetoprotein. So the question is now to the floor is what sort of management strategies one would pursue for this patient after he's had his taste.
Okay, thank you, Wanga. I think this is a very nice case. I think that also demonstrates, Michael, some of the questions you had about what one can use to test the biology. And in this case, the patient clearly had a sort of an unfavorable course with a very quick rise, but almost as equally decline after the taste. So the question is, if this patient would qualify for curative intended treatment, that we think, even keeping in mind the problems that he had with his heart, that he may be fit enough. And the question is, you know, what we're going to offer him. So if the offerings are transplantation, a liver resection, or an ablation, and I wonder if we can ask some of our colleagues, maybe some of our ex-fellows from Cape Town. Karan, do you want to weigh in on this? Karan's still with us.
Sure,
Yeah.
Prof. Yeah, I'm still here. Thanks. It's a very interesting case. Thanks, Wanga, for the presentation. I think it highlights pretty well what we've just spoken about, like you said, Prof. And it's one of the things where we're not here nor there. So for a patient like this whose liver function has improved in terms of the Child-Pugh score, and the tumor has demonstrated a really good response to TACE, and the previous medical management didn't really work so well. So I think this is a case of favorable tumor biology. And I think in terms of the outcomes for this patient, perhaps a transplant would be the best option, because you get rid of all the tumor burden as well as the diseased liver. So if this patient could be offered a transplant, I think that would be the most ideal situation. But if a transplant can't be considered, where, for example, in most of our settings, then I would offer this patient a resection, bearing in mind that the residual liver is cirrhotic, and we should try and spare as much parenchyma as possible. We can see that the tumor lies pretty close to the left portal vein. So I think here, most likely we can get away with the segment 2-3 resection, but of course that intra-op we'd have to take all the branches that lie to the left of the left portal vein and spare segment 4. That would be my take on this. Thanks.
What about ablation? I see Rashid Nashidengo from Windhoek is on. Rashid.
Hi, Prof. Hi. Thanks, Wanda, for a wonderful case. Yeah, so yeah, ablation, Prof. I'm just a bit worried because it's quite close to the main portal vein, and you might get a heat sink effect, and you might not really ablate the tumor entirely to good success. I'm just worried about, Karan mentioned about resection. The right side looks very atrophic. Do we know maybe the volume size of the right side, including the segment 4? Yeah. But for my answer for the ablation, I think it's going to be very difficult because it's very close to the vein, and you might get a heat sink effect, Prof.
I think that's a valid point, Rashid, and certainly you don't want it. You want to cure the patient. What would concern me a little bit is the proximity to that vein, is that you create some havoc there, because if you get a portal vein thrombosis in that sort of vertical part of the vein, and that would extend to the confluence, that you're probably going to run into or the division of the portal vein, that you're going to run into severe problems there, because I think portal vein thrombosis in this patient is if not kill the patient, it's going to make him sort of unsuitable for any form of treatment in the future. But yeah, the other thing that we wondered about is one can go for only a segment 3 resection. But again, you have to be very careful not to injure the bile duct to draining segment 2 as well. Any other comments? So the jury is still out on this patient. He's 70 years old, and that's a little bit sort of at the higher end of the age spectrum that we would normally consider transplant on, but we certainly would have a look at that. And I think the other option then would be to do a resection on this patient and try to do a parenchyma sparing resection, if possible. Mark, any more comments from you? Was Mark has maybe left us. Yeah, so I think we within. Yeah, sorry, Mark.
We lost internet for a little bit. I didn't share what Rashid was saying, but one of the other reasons why I think ablation is not a good idea is because in this case the segment 3 vein looks like it's invaded. So it's not, the umbilical portion of the portal vein is intact, but the segment 3 is invaded, and I'd be worried that if you just ablated that lesion, that you'd get satellite lesions in the rest of segment 3. I'd also be worried about resecting segment 2 and 3. I think it would be quite nice if you could just resect segment 3. I don't know if you mentioned that. I think you could probably try and just resect segment 3 because he's got a hypertrophy of segment 2, 3. I'd worry about resecting too much liver if you took that out. I think it is resectable. Transplant would be an option, but I think because it's resectable, I think we'll go with resection.
Okay, I think that very nice sort of summarizes it, Mark. All right, we've got about a minute to spare, so if there are not more comments or questions, it just remains for me to thank the speakers. Thank you, Michael, for a fantastic presentation, Mark and Wanga. Also want to thank the ECHO University of New Mexico team and also the ECHO India team. There is a feedback form available in the chat, so if you've got any comments on how we can make this better, more interesting. We also mentioned before that if there's anybody that, any of the colleagues that have got interesting cases to share from other countries, we would really welcome that. So if there's anything you want to share with us, we will work it into the program. The recordings of these meetings are available on the Gastro Foundation website, so if you want to look at them again. And then lastly, just to thank Sharon and Karen and also our sponsors. And then next week's GECO meeting will be on IBD, and the program will be coming during the weekend or just after the weekend. Thank you very much.
Prof.
Yo.
Just before you go, I just wanted an opinion on a patient, if I may.
Yeah, sure.
It's a patient that is 60 years old, good performance score of 1. He has an Hcc on the right side related to hepatitis B. We almost planned a right hepatectomy, but we're just concerned about the liver on the left side. So we did a laparoscopic exploration. The liver looked micronodular, and we did a biopsy, and they reported grade 3 fibrosis. Will that preclude a resection, or can we rather just taste the patient? What your opinion, Prof?
So I must say, the fibrosis grading has not been well. It's not been properly looked at as a predictor of liver function in the context of liver resection. I would be quite interested in what we use so far, what the Child-Pugh score is, what the MELD score of the patient is, and then if there are any signs of portal hypertension. I think those, we've mentioned, those are the surrogates that we use. But
So I worked out his Child-Pugh is class A. And I can't remember his MELD score, but it's not really elevated. His biochemistry is pretty normal. And it doesn't have features of portal hypertension, both clinically and also on imaging.
What operation are you planning? A right hepatectomy?
A right, yeah.
I think we had one recently that was similar to this. So I think you should work out the volume, and if it's close to 50%, you could consider doing a portal vein embolization. Just, I'm not saying that you have to, but if the volume is more than that, then it's probably okay to go ahead. And what's the etiology of the liver disease?
Hepatitis B.
And that's controlled.
Yeah, it's controlled. Yeah, we started him on I think
so
for a month now.
Yeah, like normally you would only do a portal vein embolization if it was, 30% or so. But in this case, where you're worried, you could consider that.
Okay. Thank you.
Yeah, but Rashid, so I mean, our next meeting I think is in about 5 weeks. But yeah, we can put that patient up for discussion as well. We've talked about it now, but we can maybe talk about the outcome then.
Okay, Prof. Thank you so much.
Good.
Bye.
Thank you very much, everybody.
Thank you, everyone.